just to give you some background, PEMeast was started 2 years ago by trainees who identified a gap in the East of England training programme for PEM speciality, and it's all done in trainees' spare time. So really appreciate anyone contributing with the GoFundMe page. So I'm just going to load up these slides. And the topic today I'm going to talk through is PEM ABC, so buying yourself those extra few minutes. And the reason I was going to talk about this, I've had my first year now as a EM consultant and PEM consultant, and I think this was sort of the thing I reflected on that hit me most over that year, things that I never regretted doing. So cases where I was really glad I actually did interventions that bought me those extra few minutes, but it was when I really needed them. So sometimes we'll talk through a case, but sometimes you've got a decision where you may have to do an intervention. It will take a little bit longer in the moment, but you're in a situation where you actually have control of the situation, and spending a few minutes in that time can actually be more valuable when you need a time critical advantage. So particularly, after an induction for an RSI, things that you've done to optimize the patient. And I think it's just keeping that in mind that as you go into your senior training for those who are nearing their CCT date, that I think as the team leader, as the EM reg, as the paediatric reg, or for those joining us from other teams, there'll come that point where you may have to have that difficult conversation where you actually do want to advocate to buy yourself those few minutes later on. So it's going to be an interactive case. There's no right or wrong answers today. So these are all dilemmas where most options are correct, or there's no incorrect option. It's just I would like to have an open discussion and get people's thoughts and see if we end up at a similar conclusion. And I think this is the time to have those discussions, think through these difficult situations. So in the moment, you haven't got such the cognitive overload when the adrenaline's running and you're in that kind of resus scenario. And today there's multiple talks that I'm hoping are going to cover quite a lot of your queries in terms of your troubleshooting requirements for paediatric emergency medicine resus. And I just wanted to form a word cloud. If you can give a word or two for any topics you would like that you think would be good to come up today. And I just want to see if actually you end up by the end of the day, many of them coming up. So we're getting a few coming in: trauma, major hemorrhage, sepsis, cardiac arrest, inotropes, more for trauma, more for inotropes, NLS, jaundice, team management, airway emergencies. So you'll be pleased to hear we've got, I think, 2 talks from retrieval specialists who are going to look at both stabilizing the unstable patient and particularly at circulation. So that's likely to be covered today. I'm going to talk through some parts of our case will involve the team management, airway emergencies, sedation's popped up as well, toxicology, cardiac arrest, hypothermia. This session, we're going to talk about, really going to focus on the preparations for a critically ill child, and then looking particularly at the A, a bit of the B, we'll touch on C, and then later today you may touch on some of the other areas. We're going to look at options for your preparation with your 0-point survey, your drug calculations. We're going to look at A in terms of how you can optimize the paediatric airway, particularly thinking about checklists, your plans for can't intubate, can't ventilate. And then we'll touch on optimizing the patient to avoid post-intubation hypoxia, and touch on how you can improve circulatory response with your RSI drug choice and preparing your emergency drugs. So the 0-point survey, I've just put in some references from, originally I think Cliff Reed had set up one of the sort of emergency medicine heroes, but he'd set up this article in CEEM, and that was a kind of first introduction with Simon Carley to the 0-point survey, where we're all really familiar with our primary survey and we have that drilled and trained in our life support courses, but actually before that there's the potential to really influence your efficiency as a team later on and to buy yourself those minutes. So if you have got a patient where you're getting a pre-alert, the 0-point survey uses the step up mnemonic. And I can never remember these mnemonics, but the main thing is to think about, yourself. Are you physically ready? Are you safe? Do you need to take a deep breath? Do you need to go to the loo? Do you need to get a quick drink of water, quickly get something to eat in the time? Are you ready to be the team leader or part of the team? And then the T is for team, and making sure the team leader is identified and the other roles are allocated, the team's briefed. Check in E for your environment. Is it safe? Have you got to create the capacity because you've got a full resus? Do you have appropriate space for your team that's likely to be a large team for a paediatric resus pre-alert? Is it suitable lighting, crowd control? Are you going to have to sort of limit who actually comes into the clinical space and set up a crowd control for your team as you call them in? And then P is, as the resuscitations commence, you've got your patient, then you move into your comfortable sort of primary survey, A to E, that you're familiar with. And during that time, the U is to remind you to update and share your mental model with the team. So once you've got through your primary survey, I find it really useful to give a summary, confirm that you've understood all the positive findings, and share the priority with your team. And P for priority. So identifying your team goal. Is that going to be your plan is to go straight to scan? Are you getting to IPICU? Are you going to theatre? Are you having to transfer to another hospital? And you can keep repeating that cycle back as you need to reassess your A to E, update your team, and highlight your priority. And I find that really useful way to just base yourself, ground yourself, and it also helps talk through your own thinking as well. So the other thing with preparation time is just, I mean, I'm a big fan of a checklist. So I'm a person who needs a checklist to remind me of the details in the moment, and just keeping in mind your options. So depending on your pre-alert, are you likely to be needing your RSI checklist? Are you likely to need to set up for major trauma? Is this a patient who you're going to be directly transferring either straight to theatre? From what you've seen, it looks like they're needing to go straight there, or you're going to go straight to CT. Are you going to have to prepare for retrieval onto another hospital, or even just another part of the hospital? So just a reminder about a few resources. Panda, our East of England paediatric retrieval team, have now updated their website, and they have included the stop transfer tool. So if you're preparing retrievals, you don't have to wait. You can start thinking about that before you even receive the patient, and you can delegate that to someone else whilst you're making the preparations for your immediate primary survey and resuscitation. Your RSI checklist. So Panda, I think haven't yet updated their website with the RSI checklist, so I really like the CATS checklist, and there's various models for this. Each ED probably has its own version, and I know we've got our own version for adults and children that we use with both. So this one might be slightly more specific to children from CATS, and that's available through the CATS in a hurry section on their website. And then the ED transfer, your own ED may have its transfer checklist, and the new APLS 7th edition has a really nice sort of generic major trauma checklist. So again, we have our own local one referencing local services, reminding us that we need to actually call our paediatric surgeons separately. We need to call our paediatric anaesthetists separately. We need to contact IR surgery, reminding us things that we can do in advance because of the lead time. So there's often for us a 30 or 40-minute lead time to clear a theatre space or to get IR set up. So making those calls early, if we're going to need teams from other hospitals, cardiothoracics, making those calls early. But this is a nice generic reminder. It adapts the wet flag and includes the sort of trauma approach to the wet flag. And it's got some really nice analgesia doses. I was also quite excited to see they've included intranasal ketamine, which might, again, buy you some time and get control of a situation in patients where you might want to avoid opiates on their arrival. So yeah, it's worth having a look at the new 7th edition appendix. And then in terms of drug calculations, personally, I just find the Paediatric Emergencies app the most reliably sort of covering all bases based on UK guidance, linked to guidelines. It's worth having a go. If you want to download it today, there's a light free version you can start using it with the cases today. Once you've kind of established the way in, you just need to basically tick the male or female, age, and then you have to guess. You have to either click estimate to get their estimated weight, so that gives you the W of your wet flag, press next, and then you can get into all the guidelines. I just find it the most useful resource. The other version is £4, but I think it's the best £4 I've ever spent. It will give you the exact mils, the dilution of the drug, so you can hand that over to your nurse, drawing up all your infusions and drugs. And I think it's a lot safer than trying to do mental arithmetic in those situations. And there is now a Panda Paediatric drug calculator. It doesn't include the RSI induction drugs, but it does include infusions. And to get to that, if you go via the guidelines for professionals, you can then either pick the pediatric or neonatal version, and you download it as an Excel sheet. Just a tip that it only seems to let you see the calculations once you've sort of saved it as a PDF instead of printing it. If you don't want to have to access a printer in these moments where you need a degree to get an NHS printer to work, then I recommend just save it as a PDF and you've got it on your Resus computer then, and that will give you all the calculated doses. And it's worth knowing you do need to put in the details in the yellow box to get it to calculate. So after, if you've had a pre-alert and you've made as much preparation as you can, you've gone through your checklist, that's the perfect scenario where you've got as much time to prepare as possible. And then there are those pediatric resource scenarios where you don't have time to prepare. So the case we're going to base our discussions on today, and this one starts off where you don't get a pre-alert, you're actually responding to the emergency alarm in the resus in the emergency department, and it's an 18-month-old patient with a background of cystic fibrosis who seems to be in respiratory arrest, and they've been admitted or they're being observed with suspected pneumonia. You've currently got with you one paediatric ED nurse or equivalent, and they're already doing a jaw thrust. They've already got 15 litres high flow, oxygen on, that mask isn't steaming, and the lips are looking blue. So you start to plug in the BVM, your 222 calls being placed, you have no visible chest rise or regular respiratory effort without spontaneously. Your patient's SATs are picking up, trace is picking up reasonably well, and they're 73% on 15 litres. So you carry on with your BVM ventilation, you get chest rise, and you give your 5 rescue breaths. Your SATs that respond to that, and you've got a good end tidal waveform. You start to move on and delegate your A to E assessment. You may then at this point have more people arrive, so you can delegate your airway to someone as you take over as team leader. And in your C assessment, you have got a palpable pulse. It is over 60, so you're not thinking you're in cardiac arrest. They're pale, they're shut down, they've got a bit of a low blood pressure, and no features of congenital heart disease, no features of acute abdomen, and they get IV access is gained, they're getting their 10 ml per kilo bolus. Your D assessment, they're starting to become more responsive after the BVM ventilation and improving SATs. You start to get a motor score of 2, and that carries on improving over the next few minutes. Equal pupils, normal blood sugar, and they're slightly cold, 35 on their E assessment. Nothing else to see on exposure, no rashes or bruises. So as your senior consultant, your anaesthetic team from the arrest court arrive, they start to prepare an RSI checklist. Is there any other specific team members, if you're going to be team leader, that you want to call? And most people wanting anaesthetic consultant or paediatric anaesthetist to be phoned, half of people wanting an ODP and half wanting to let the retrieval team know. And I guess that is dependent on where you work. If you're working at a place with a PICU, then I guess that would be equivalent. I should have probably put retrieval team / local PICU team. They would be on our cardiac arrest call, so they should already be arriving. So I wondered if in the chat, or if you want to turn on your microphones, if anyone can talk through their thinking why they would like the paediatric anaesthetist or the consultant anaesthetist.
I think my concern was, especially early on, it almost looked like there was kind of impending kind of respiratory arrest. And the patient's got cystic fibrosis, so they're just much higher risk. So the fact that we were having to bag early, I would be kind of preparing for the worst case scenario that we might need to intubate.
Yeah, exactly. And I think Alex has replied as well, saying this child has minimal reserve oxygenation given the age, type 1 respiratory failure, and will desat really fast. Yeah, so children are more likely to desaturate anyway, and this child already has a higher risk factor diagnosed with cystic fibrosis. Charlotte, we've already been in a respiratory arrest scenario, so this is not going to be a patient where you have a lot of time after their induction to deal with hypoxia. And I think it's going to be the most common problem, even though this patient doesn't seem to have any known structural airway problems. There's no known difficult airway. Every child can be a difficult airway for someone who's not familiar. So it's interesting, in this case, I actually asked the on-call anaesthetist, would you like to call your consultant and the paediatric consultant? And they said no, which I was quite interested by that response. And it does already start the kind of discussion of trying to respect their kind of training and wishes, but also knowing that there's no reason not to call. I think you've got a very sick child, critically ill, and you're anticipating that it's going to be a difficult intubation. Although they may not have a difficult airway, they're going to really desaturate quickly. So in that case, I explained why we would call them. The other options included ENT. So I think the ENT are ones where I certainly would want to phone them if I had the anatomically difficult pediatric airway. And I think, yeah, if you're concerned you're going to be going for front of neck access options, then I would certainly call them. But this patient didn't particularly raise that concern. So in our checklist, we've worked through preparing for difficulty, and the other question that comes up again in preparing for team right at the end, are any additional staff required? You do need your airway operator, your second airway operator, your drugs person for induction, your person doing monitoring. So you do need quite a few people around who are going to be not pulled away to other resus cases. And then preparing for difficulty does also include, in this CATS version of the checklist, a discussion about your strategy for dealing with difficult intubation. So I think these conversations often are dependent on how much time you've got. Have you got 1 minute to have that conversation with the team, so you're all using the same kind of model, you're all prepared for that scenario? Or is this a crash intubation where you've just got to carry on? And I think we've got good SATs on this patient, we've got good chest rise, we're giving treatment for circulation, and I think we do probably have a minute to have that conversation. And it's interesting because the DAS guidelines actually contradict the APLS guidelines in terms of ages, when to do what for your front of neck access, for your can't intubate, can't ventilate scenario. So there can be sometimes a bit of discussion about what people are most familiar with. So have a look through your DAS guidance, but that's usually my first port of call. And for a child between 1 to 8 years, if ENT aren't available and we end up doing front of neck access, then our first line is likely to be the needle cricothyroidotomy. If that fails, then I think probably as an EM person, my next step is going to be to move on to a surgical cricothyroidotomy. If you've got ENT around, they're going to be potentially going for a younger child, potentially straight to tracheostomy. And I just wondered if you've got any sort of difference of opinion, what would be your first line for an 18-month-old? Because I know the APLS guidance is actually to avoid the needle cricothyroidotomy until they're over 5, I think. I'll just wait for a few more answers to get in. It looks like the majority are going for needle, but I can see some people are more familiar with surgical cricothyroidotomy. Potentially at 18 months old, it is going to be a very small target. Here's a summary between the different guidance. DAS goes down the line. If the needle cricothyroidotomy fails, then you go for surgical. APLS seems to say go straight for surgical cricothyroidotomy if you can palpate the cricothyroid membrane. So between 1 and 5, less than 1 is the tricky area for both guidelines, where really it just advises ENT tracheotomy. And I think in those age groups, if I didn't have ENT there that minute, I mean, personally, it's an area where I've not been trained to do tracheotomy in a less than 1-year-old. And I think probably as a sort of last resort, I would still try a needle cricothyroidotomy, but you're really only aiming for, their cricothyroid membrane, less than 1 on neonates. We're talking like the size of a grain of rice. So it's going to be very challenging. And there are various other guidelines. There's mention of converting your needle cricothyroidotomy into a wire-guided cricothyroidotomy. So that's something usually I think we'd probably need sort of ITU anaesthetic input for. So you've got through your preparing for difficulty, and you're now being asked to prepare the RSI drugs. So what are you going to go for? And I think it will often depend on if we've got many anaesthetists in, or if we've got who are more familiar maybe with propofol, if you've got more EM, peds or PEM people in PICU may be more familiar with ketamine. So it looks like the most popular option is the ketamine 2 milligram per kilo with rocuronium 1 milligram per kilo. And I wondered if anyone in the chat can give their rationale for why they've gone for that option. I think AJ's explained no need for fentanyl as ketamine is pain relief as well. Charlie's put in risk of dropping blood pressure with propofol. Yeah, I agree with both of those points. And Alex has agreed that GCS is 4, so don't need fentanyl. They're already quite knocked out.
And also the third choice of ketamine 1 milligram, I think it is lower than what is needed.
Yeah, I think it originally came from pre-hospital inductions where they were using the 3-2-1 as quite a common regime. 3-2-1 would be 3 mics per kilo of fentanyl, 2 milligram per kilo of ketamine, 1 milligram per kilo of rock. And if someone was completely flat, if they already had a low GCS and were very cardiac and had severe cardiac instability, then they're actually doing the 1-to-1, which is ketamine 1 milligram per kilo, rock 1 milligram per kilo. So that is an option for the really, I'd say the peri-arrest patient who you don't want to lose their cardiac output. There is that option for the lower ketamine dose. So I think often for those working in theatre, they're more familiar with titrating propofol. They'll often give it with a chase of kind of a vasoconstrictive bolus, and that's how they're used to working. But I do worry about it in the context of this patient who's shocked, low blood pressure. They're, already had a respiratory arrest, so I think they're a high risk one for propofol. Often, again, this is a discussion that genuinely does need to happen in resus, and the team leader and the airway expert often do have a discussion around this. Same with infusions after induction. So again, I'm quite happy with a ketamine infusion if they're having any hemodynamic instability, but PICU often go for morphine midazolam, which they're really familiar with as infusions, and in the long run has probably less complications for their patients waking up. So yeah, it was interesting just actually genuinely looking at the doses. So fentanyl is advised, you can use it for neonates and children, but APLS advises only over 7 kilos and actually gives much smaller doses. Propofol, apparently BNF's happy with use from over 1 month old, but I know people are using it younger than that. Ketamine suitable for neonates and children, and rocuronium, again, suitable for neonates and children. And just a reminder that the RSI dose for rocuronium is the 1.2 milligram per kilo. We tend to round it down to 1 milligram per kilo, not to get mixed up with many of the drug calculators, which give you the elective anesthetic dose, which is 0.6 milligram per kilo. That's for a slower induction for a patient who's starved. So don't be using that for your rapid sequence induction. You've got an unstarved patient, you need a quicker paralysis, you haven't got time to wait. So I did think in this case, because they had hemodynamic instability and they were already quite knocked off at GCS of 4, I don't think you'd be wrong for going for the 1-to-1. 2-to-1, I agree, is probably another good option. But again, there's no right or wrong answer. These are just suggestions. And like you said, 1-to-1 may not be enough. If they're waking up as you're bagging them, then I think 2-to-1 sounds like a good option. And there's no really good evidence about fentanyl in children that I can find. And the best thing I've found was this study and this critical appraisal through St. Emlyn's regarding the study about fentanyl versus placebo with ketamine. And they did find lower blood pressures more common when you add in the fentanyl. Fentanyl isn't adding that much, like you say, because ketamine's already got analgesia and it inducts the patient with sedation. So I don't necessarily push for adding in fentanyl, but again, we don't have much evidence in the children's group who are a bit more sensitive to bradycardias with laryngoscope blade stimulation. And there were actually no difference in the primary outcomes in this study between those with fentanyl and those without. So if you're going, let's say we do go for the 1-to-1 because the child's not waking up anymore, they're still GCS 4 with the BVM, what volume are you going to draw up for your ketamine and your rocuronium? So we've got an answer for your 1 ml of ketamine, and your 1 ml of rock uranium with the 10 milligram per ml strength of ketamine. Yeah, so that's what I was hoping you'd go for. It was just a reminder. On the whole, I think ketamine is a safer drug in these scenarios, but one of the main risks is the fact that you do have these 3 different strengths in some resus areas or intensive care areas. So it's really just to be careful that you are using the 10 milligram per ml option. And I was just going to run through a video just to get this kind of imprinted in your mind about why we want to avoid mixing this up.
It's 4:45.
Can you hear that okay?
Dr. Bish Elangbaum has been working since before midnight.
Yes.
And it's been a busy shift.
Hi, Leon, it's Bish here.
A girl has been run over by a car after stepping into the road when dropped.
Lena, pause. Pause. All right, can we get some fruits through? Molly, over here, please.
Taxi for 20 minutes with one of the next. The burns on the leg.
Yeah, so we're doing it for the negative goal.
Danielle's legs have been shattered, and doctors are worried by the extent of her internal bleeding.
Okay, well done. Okay. You want some more painkillers, Daniel? You want some more painkillers? Can I get some more morphine?
Danielle is in urgent need of more painkillers, but doctors decide they can't risk giving her more morphine. Instead, they opt for another drug, ketamine. By mistake, Danielle is given an overdose, 10 times as much as was called for. To her boyfriend, she was all crossing the road to go home, and then issues into the car.
CPR, please. Okay, get a little 1 minute, please.
The overdose sends Danielle into cardiac arrest, and her heart stops beating.
Okay, so that was for a 20-year-old, and if you didn't catch at the end, goes into cardiac arrest due to a tenfold overdose of ketamine. Although it was a 20-year-old, it could have very easily been a teenager, child hit by a car. And there's a lot of interesting points that, you could go into discussions about, are you going to do chest compressions in a traumatic cardiac arrest? There's a lot of things you could debate how you're going to lead your team in that scenario. But I think the main thing you take away is just imprint that on your brain to double check the ketamine ampule before, if you're particularly the one responsible for induction, make sure you're checking your drugs. I think it's interesting, the verbal kind of communication, they said 50 of ketamine, give half, and I didn't hear units, didn't hear mils, so just be really careful about that. So next question is, do you want to prepare any other rescue drugs? Okay, so it looks like everyone's pretty happy with getting a fluid bolus ready. Atropine seems to be popular, and I guess again because of that potential for bradycardia with younger children being intubated with their stimulation of the laryngoscope blade. Adrenaline push dose, only 40% of you, and then metaraminol 20%, Sigamadex 10%. So for those who aren't familiar with each drug, metaraminol is often, if you come from a paediatric background, you may not have used it very often, but it is used in theatres with children, particularly if they're on propofol, they need some vasoconstriction, and Sigamadex is a reversal of paralysis that, again, often in theatres may be used. So I would advocate for preparing, for sure, the fluid bolus. Often with these children who are already unstable, I would get the adrenaline push dose ready. And I think the reason for that is, for me, the rush of trying to calculate adrenaline push dose bolus after patient has already, deteriorated, I think you've only got moments really, and you don't want to be trying to work out mils and calculations. So what I tend to use is, if you get the cardiac arrest dose of adrenaline calculated for a child, you can then dilute that up to 10 mils, and 1 mil will be your equivalent of your push dose IV bolus, your aliquot that you're going to give, not your cardiac arrest dose. So I also think if you're getting that prepared, you may as well prepare one for a cardiac arrest as well. You've got that to the side. But I think those are the things that are very fiddly to do when the patient's suddenly deteriorated. And often you've got one nurse, maybe two, who are familiar with paediatric dosing for adrenaline. So you're going to be using them in that scenario for other things. So at least you've got that ready. And then the atropine, I think probably I'm moving more towards preparing atropine as well, or at least having it to hand, ready to go, dose ready to calculated. And I probably wouldn't prepare Cigamodex. It's not an elective intubation. So if you do end up in a can't intubate, can't ventilate scenario, you're not going to reverse this patient, because you still need to intubate. You're not going to reverse the neuromuscular blockade. You're going to carry on with your DAS algorithm, work through your A to D. I can't imagine many scenarios where you would want to reverse in these situations. And metaraminol is controversial, as we discussed. The BNFC only advises over 12 years, but again, I think it is often used off license in theatre, especially if they're using propofol. So we've got through the first bits of the checklist. We've prepared the difficulty, prepared equipment, and we're looking at how we're preparing our patients. So luckily this child, we'll say for this case, has already got an NG inserted, because they'd come in with pneumonia, they weren't feeling well. So you've got an opportunity to quickly aspirate your NG. And this is something that often won't be included on your adult RSI checklist if your resus are using a joint adult paediatric one. But that's going to really help your reserve in terms of improving your pre-oxygenation if they've got a full abdomen. If they've been bagged and they're full of air, it may help as well. And the question in terms of optimizing your patient for your RSI, so you've got through to your section and you're thinking probably going to confirm their IV access is working. You might want to get a second line. Most people are going to use a Mapleson circuit to pre-oxygenate, BVM, ventilate, and I think commonly now we're giving apneic bag valve mask ventilation during the time after their induction, and they're having the apneic phase. If you're really worried about the patient, I think a lot of us have moved to that. But then the question is, you've done your optimized position, you've aspirated your NG. Is there anything else you're going to do? Are you going to give high flow nasal oxygen? Or are you going to give low flow nasal oxygen? Or are you going to give no extra nasal oxygen? So it looks like just over half are going to go for the high flow nasal oxygen. It's interesting because originally, I think previously I would have gone for high flow nasal, but there's a number of reasons and change in evidence that have pushed me now towards low flow nasal, and especially in terms of saving time. So high flow nasal probably for us would take at least sort of 15 minutes to set up. We actually store it in our paediatric ED. The high flow nasal is a lot bulkier, so I found it can be a bit more difficult to get a good seal than the low flow nasal oxygen. And there's actually now evidence for paediatric patients that there's not a huge difference in outcome with high flow and low flow nasal oxygen. And so if you want to have a bit more look at the evidence in detail, this one was from, I think it was 2023 maybe. This was from the British Journal of Anaesthetic, and they looked at all forms of nasal oxygenation during the apneic phase. They actually merged them all together. So this study didn't really clarify low flow versus high flow, but they lumped them together, and they found that with either of those, it actually increases the first pass intubation success rate. And I think that probably could be because it gives you more time to get the tube in first time. And it did also maintain oxygen saturations for longer. Then trying to compare the low flow nasal versus the high flow nasal, there's a few kind of narrative reviews. There's one here that has a really useful table giving you the kind of pros and cons of each, and a lot of them we've kind of already talked through, but again, there wasn't a big evidence base for this. And then there was this study by Riva and her group that was actually from 2018 that compared nasal, high flow, low flow, and that was interesting in that it compared them at various different rates and slightly different techniques, but it uses the 0.2 litres per kilo per minute for the low flow nasal oxygenation, and it looked at 2 litres per kilo per minute for the high flow. And it actually didn't find that it extended the safe apnea time for children in the 10 to 20 kilo range group. Again, it's looking at a specific age range, 1 to 6. And it did show that there was no ventilatory effect from the high flow. So there was some theory that the high flow would actually help with a little bit of CO2 clearance as well. But I think at this point, our priority is the oxygenation in the apneic phase. And it was interesting to see that it didn't actually improve that saturation time. So for me, I think I'm going forward, probably it's quicker for me to get low flow nasal set up, but I don't think there's a right or wrong here. Again, I think you could definitely argue for high flow with this high risk patient with cystic fibrosis to give you that longer time. So after all that preparation, we've got about 10 minutes left. So coming to the end of the talk now, but just to give you an update on the outcome of this patient. So they actually had a first pass tube. We did low flow nasal oxygen. We had good end tidal CO2. As we were getting the tube through, our paediatric consultant anaesthetist did arrive, and our consultant anaesthetist adult side had already arrived. But after the tube was passed, we actually started to get desaturation. So we were working through our dopes, and the anaesthetist initially was quite convinced that the air entry was equal, but it's a very noisy environment. And on listening, we then looked at whether we had actually gone too far because this child was very underweight. So our tube length calculation, we could have actually potentially reduced the estimated weight for that calculation. So we pulled the tube back. There wasn't much improvement in the SATs. Then we passed the suction catheter. There was no obstruction of the ET tube. And actually at that point, it potentially picked up some mucus plugs lower down. I think we passed the suction catheter relatively far. But at this point, the patient had desaturated to 76%. Their heart rate had dropped lower than 60. So we actually did start briefly for a few moments, chest compressions, atropine, adrenaline was prepared. But in the time that was prepared and we'd suctioned that mucus plug, their SAT started to improve, and their bradycardia, which I think was related to the hypoxia rather than the intubation, that improved, and then their saturations came up. So we didn't have to move on to the next sort of stage in the dopes mnemonic. But just a reminder, you could then move on to increased PEEP, looking into decompressing the chest for pneumothorax. Do you need to do needle decompression, checking your equipment, and you've already got them onto a bag. You're not on a ventilator with our case. And then whether you've got stacking of breaths, if you've got an obstructive wheeze patient, just thinking through your doped mnemonic. And for the D, I've also just added an extra D, rather than just displacement of the tube. Just remember, distension of the abdomen for children can also give them quite a significant hypoxia. Probably not the most imminent life-threatening cause, but it's something that could contribute to the desaturation. So this patient was stabilized. They got to PICU. They were extubated. That brief cardiac arrest, we would define it as a cardiac arrest because the heart rate was less than 60. And actually, I wonder if the chest compressions helped dislodge a mucus plug. That may have been another contribution to improving their SATs. So that was that case. I just wanted to sort of share some of the learning I had from that case. And yeah, I was just really glad walking away after that we had done what we could to optimize things. I was really appreciative once the paediatric consultant arrived, as things were going the other direction. It really helped. So in summary, we've talked through preparations if you do get a pre-alert, your 0-point survey, drug calculator options, and your checklists. We've talked through A, and optimizing the airway, your front of neck access potential plans. We've talked through B, for your induction, trying to avoid that post-intubation hypoxia. And don't forget the simple things like positioning going forward. We've talked through high flow nasal versus low flow and DOPS algorithm for a post-intubation desaturation. And we've also looked a bit at how you can optimize C with your choice of RSI drugs and emergency drugs. So we've got now, I think, about 5 minutes. If anyone's got any discussion points or any questions at all, feel free to send.
While we're on this question, is it your practice to draw up rescue medications?
So I think as a minimum, I would do the drug calculations on the board with the exact mils, so everyone knows if you ask for atropine dose, if you ask for adrenaline push dose, and I make sure it's clear, or adrenaline cardiac arrest dose, exactly what you want, because I think you need to take those mental arithmetic out of that situation, which is going to suddenly become very high adrenaline scenario where you've got very short time and your precious resource of your pediatric nurse is you're going to lose them. If they're making drugs, you've lost that 1 or 2 paediatric nurses. You're lucky if you've got 2, and the adult nurses often aren't comfortable drawing up these drugs for children under that pressure. So my minimum would be the 10 ml per kilo bolus. Have that ready, because you know you're going to give them the fluid at some point anyway. But even with ketamine, you can have a blood pressure drop. And atropine, I'll have it to hand. I'll have it pre-calculated. I won't always draw it up, because you know I think you've usually got a little bit more time with the bradycardia. You've got, you know, a few moments to draw that up. But yeah, it's tricky because you're balancing waste, and I think the drug errors are more likely to happen if people are doing them in the moment of crisis rather than before, when they've got time to think it through, check it, and get you to cross-check. Thank you all. Hope that was useful, and the references are here if you want any of the references.